We are live on Facebook. Let me share my screen here. So thanks everybody for coming. I got to go in present mode here. So tonight we have Dr. J. Kalawadia and Emily. A lot of you know Emily. Probably a couple of you know me. We're the PTs at Robbins Rehabilitation West. But Dr. Kalawadia you might not have seen. So I'm a little biased. I think there's lots of great knee guys and girls in the area, but Dr. Kalawadia is my favorite. So if I have a patient that needs an ortho consult, then I typically send them over to Jay. But tonight, what we're going to do is just go over from a patient's perspective. So we are the orthopedic surgery and physical therapy, and we have all the anatomy and physiology background, but we really want to try to help you guys out in terms of making decisions about what to do, because it's pretty uncommon for you to go through an entire life. I don't know. We see some pretty old patients, Dr. Kalawadia, but it's kind of rare to go through life without some form of knee pain. It's kind of similar to back pain. It's really hard to get to an older age without getting some form of pain in that area. So it's super common. And what we want to try to do is help people make a decision about what to do if they do have knee pain. Good news, it's not always surgery, so you don't have to freak out. Dr. Kalawadia is one of the most conservative surgeons that we work with, and that's probably why we like him so much, because we're trying to actually do everything we can up into surgery in order to handle things conservatively. But sometimes the fact is surgery is a great tool to use when you have knee pain. So I'm just going to ask questions, and then Emily can jump in what she wants to too. If you guys have questions, we're going to wait to the end to put those. You can either put them in the chat if you're in Zoom. If you're in Facebook Live, then you can just put them in the chat there as well. And then if you have any questions, we're going to do that. But these are the most common questions that we get. And we asked our email list if they had any questions, and we pulled some of those from there. So Dr. Kalawadia, I want you to kind of explain as easily as you can the knee in terms of the joint and what it is. And when a patient comes in and says they have knee pain, there's, a lot of things that can be causing that, but go through some of the most common things that can cause knee pain. And if someone steps awkwardly or twists their knee and there's some kind of traumatic injury, sometimes that's a little bit more straightforward. But a lot of our patients just kind of say, I guess I was doing a little bit more activity, or I just kind of woke up and my knee started bothering me. I don't remember doing anything to it. So from that perspective, I'm the patient, I'm coming into your office and I have knee pain. What is going on there?
So, before we can even answer that, it takes a little bit understanding of the anatomy. And you got a good picture right there. And so there's numerous causes of knee pain, but anatomically, the knee has four major ligaments to it. The ends of the bones are covered with a type of cartilage, and we call that joint cartilage or articular cartilage. If you've ever eaten chicken wings and you crack the wings apart and you see that shiny white on it, that's no different than our knee. The only difference between us is that and other animals is that we have something called the meniscus, which you see in the diagram. And the meniscus is a C-shaped disc, so you got two of them, and they're also cartilage, but it's a different kind of cartilage. It feels like your ear, has the same width and thickness of your ear, and it's made of the same cartilage as your ear, and it also functions as a shock absorber that we have as humans. So when you typically tear a ligament of the knee, it's usually something high energy, like skiing or falling or slipping on the ice or soccer or something. That will be very, very obvious that like when patients come in, they'll have a story. They'll say, I was doing something and all of a sudden I had sharp pain and my leg went one way, my body went the other. And but majority of the pain that we see with patients when they just wake up and say, I was just kind of doing my normal thing and started having pain, it's usually not a ligament issue. It's typically a cartilage issue. Now, it depends. Is it the cartilage that coats the end of the bone, or is it the meniscus? And they kind of go hand in hand. And so when you're young and you're like 15, 20, 25, 30, 35, doesn't really matter. If your knee is healthy, and when I mean healthy, there's a significant amount of cartilage, we tend to think it could be more meniscus. Now, having said that, the way the cartilage works in conjunction to the meniscus is it's similar to if you got a new pair of socks and a new pair of shoes and you went hiking on the Appalachian Trail, let's say, and you went for a 3,000-mile hike. There's no way you're going to wear out the shoes without wearing out the socks as well. And so in that analogy, the socks are the meniscus. So once you get over the age of 40, just from being active, all the cartilage in our knee including the joint cartilage and the meniscus cartilage, starts wearing out. So there are people out there, actually quite a large percentage of patients over the age of 40, where they grabbed them and they said, "Do you have knee pain?" And these patients said no. They got MRIs on them anyway in this study, and they found out that a large percentage of them, more than 30% of them at 40, start having asymptomatic meniscus tears. But having said that, those tears can get larger as we get older. They can tear in certain ways and cause issues in and of themselves. So just because you have one doesn't mean it's surgical, because it very well could have been there even preceding whenever you started having pain.
Okay. And I think people they want a diagnosis. So in terms of getting you put some theories together, you do an exam on their knee, maybe get some diagnostic testing. What is your process in terms of when someone comes in with knee pain? They want to know what's going on. Sometimes it's not always, like you said, a very straightforward answer. How do you handle giving them a diagnosis and having them walk away with something that is concrete for them to kind of think about?
Well, fortunately, I mean, like in my setting, I'm sort of privileged in the sense that I usually have X-rays on the patient when I'm seeing them, and I listen to their story, like especially if they say like I wasn't doing anything out of the norm for me. I listen to their story and I'll take a look at their physical examination. When the vast majority of people start getting knee pain, they'll either get on the front of the knee or on the inside part of the knee, the medial compartment. Not always, but that's generally where it is. And so knowing that if I look on the x-ray and they don't seem to have a whole lot of arthritis, and I'm pushing on these areas that typically that's where the arthritis forms, I start thinking, well, okay, if they're younger and they don't have a whole lot of arthritis, and especially if they had some significant twisting injury, I start thinking more meniscus. If it's not that, where they don't really have a substantial injury, especially if you start seeing a little bit of arthritis in their knee, I start thinking is probably more aggravation of underlying arthritis. Now, people always think they have arthritis or they don't. That's not true at all. I mean, the fact of the matter is, like, everyone on this call is over the age of 18. So we all have a degree of arthritis in our knee. It's just a matter of how much and where. And so our whole knee does not break down similar to treads on a tire. It's not like the whole thing wears out. We'll get certain patches where it starts wearing out, and those certain patches can cause inflammation in the knee. 9 times out of 10, if you don't really have a story, and like nothing substantial like happened to you, they have mild changes on the x-ray, I start thinking it's probably just what we call an arthritic flare-up. And so that's usually where I'm starting. Now, if it's like a 15-year-old who twisted their knee like a ditch in the ground on the soccer field, very different. Then you start thinking it's probably more meniscus, because that person's not going to have any degeneration in their knee.
Okay. And for that patient that you typically come in that doesn't necessarily have a mechanism of injury, then what does treatment look like? Like, how are they typically getting rid of their pain that they're seeing you for?
So usually, let's just say that in a sample scenario, it's a 50-year-old patient, active, healthy, plays sports tries to remain active. Not even, it doesn't even have to play sports, but remains active. If I'm suspecting it's an arthritic flare-up, I usually will start with a steroid injection at that time, or oral anti-inflammatories, or some supportive breaks. Depends on how much pain the patient's in and how aggressive they want to get with that. Now, at that junction, I always tell them the inflammation that there's an inflammatory component to their pain, and there's a structural component of the pain. We're not changing anything on the structural side. That structural component of their pain probably has been there for a while, just flaring up. So if we're going to do an injection and we're going to do some anti-inflammatories, the fact of the matter is that that's only one part of it. At the first juncture, if it's just an arthritic flare-up in my mind, I will also start physical therapy, because I don't want them just to sit around and do nothing and avoid all activity, because when their inflammation goes down, now they're deconditioned, or they have some limitations in range of motion. And it's human nature. When we feel good, we're going to jump right back in to doing what we want to do. And the problem is they're not going to be ready for that. So I always tell them, like, if I'm doing an injection, you got to start strengthening and getting your range of motion back with it. Otherwise, you're going to be back here in a month saying, "Doc, it felt great, but now the pain's back."
Right. Okay. So let's say they do have a torn meniscus, and you've talked about that, where there's several examples of just asymptomatic torn meniscus. It's maybe, I don't know if you would say that, but I tell patients it's kind of part of the natural aging process, that you're going to have small nicks and kind of wearing down on that stuff. If someone comes in, maybe they have an MRI and it does have diagnosed on MRI, there's a torn meniscus. Do they need surgery to fix that? That's a lot of the questions that we give. I have a torn meniscus. What am I doing in physical therapy? Don't I need surgery to fix this? So what do you say to that patient?
Not necessarily. The meniscus, once it tears, it sort of is what it is. The only reason to do surgery is if you have symptoms from it. I am living proof. I have a medial meniscus tear on my left knee. I've had it for 14 years. It bothered me initially. I had swelling from it, but just from strengthening, I didn't even have injections, and it went away. And I had a follow-up MRI about 4 years ago. And it's not because I was having problems. It was part of the study, and it's still there, and I have zero symptoms from it. Like I can do whatever I want. So I always tell people I'm not like I would be hypocritical to recommend a partial meniscectomy or meniscus surgery for everybody who has a meniscus tear, because I have one and I'm completely fine from it. When people ask like, well, it's a tear, like what's the actual process, what's going on? It's actually smaller than most people think. It kind of looks like a hangnail that's flipping up and down. Now, one or two things happen. You develop scar tissue in that area, or the nerve endings die. But the fact of the matter is that under normal circumstances, as you're sort of doing, if it's not causing issues, there's no reason that you have to do surgery. Now, the one caveat is in kids, where they actually have the potential to heal, and there's things you can do. But like for the average person that we're seeing, usually between 30 and 60, I start with the simple stuff. Only if the simple stuff does not work, then do I consider a partial meniscectomy. But oftentimes, even the skeptics will come in and they'll say, "Doc, I'm feeling better. Do I need to do anything more?" And the answer is absolutely not.
Okay. Yeah. So partial meniscectomy, what Doc is talking about, is the most common orthopedic procedure in the United States. So they do happen at a high frequency. And you kind of talked about the decision-making process, but is there anything you just kind of exhaust conservative measures, and then once that doesn't take care of the problem, then going in there and doing surgery to repair that? What are the basic success levels for something like that in terms of good outcomes with surgery?
Well, the surgery is all over the map, like in how well you're going to do, and it's directly correlated with how healthy the knee is. So the decision's easy in like a 20-year-old who has no arthritis, who has a meniscus tear. If you go there and do meniscus surgery, I'm expecting that person to have a full 100% recovery, doing whatever they want. Now, the decision's easy on the other end of the spectrum. If someone's bone on bone arthritis, they've lost all that joint cartilage, but they also have a meniscus, kind of like that hiking analogy I use, where your shoes are completely shredded and your socks are completely shredded. In that same analogy, if you got a new pair of socks, it's not going to do much for you. And so the person who's bone on bone, when you go in there and do a partial meniscectomy, they will come out and actually say they did not get better, and oftentimes they'll actually say they got worse, because they went in with a ton of arthritis and a meniscus tear, which is expected, and they left with a ton of arthritis. And so in that scenario, the arthritis is the predominant culprit. The majority of patients we see are somewhere in the middle of that. And so it all depends on how much arthritis you see. So if you get in there and they have a meniscus tear and a little bit of arthritis, they're going to do pretty well. They may occasionally have flare-ups where their knee swells, or they have occasional aches and pains, but overwhelmingly they do great. Now, if you get in there and oftentimes you'll find out the arthritis is a little worse, that person will still feel a little bit better, but the arthritis continues to flare up. So it's all correlates to how much arthritis you have in your knee as a factor of how well you're going to do afterwards.
Yeah, that makes sense. Okay, other question we get is I've been told I need a knee replacement. How do I decide when is the right time? So do you see patients that come in and just kind of go through kind of the decision process of, yeah, I mean, geez, there's not much more I can do here. And I know you said going into any surgery, that the healthier the knee is, the better their outcomes are going to be on the other end of it. But in terms of that, making that decision of when to get a knee replacement, how do you coach your patients to do that?
I always tell them when they're sick and tired of being sick and tired, it's time to do it. And it's one of those things that with anyone who's on the arthritic pathway, they'll start getting injections. Initially, the injections will be lasting a long time, but after a certain time period, they start coming in frequent, like every 3 months. They're going through therapy. They're constantly getting these flare-ups where they're starting to bounce back, and they start giving up the things that they really like doing. Now, oftentimes I tell people early in the process, where even like as we're starting the injections, there's going to therapy, things like that, they're trying braces, taping, all that stuff. Have them start wrapping their mind around the fact that, especially if they're younger, like 50s, 60s, and or early 70s, I'm like, listen, like just wrap around your brain around the fact that you are going to get a knee replacement at some point in your life, especially if you're like young, like 60. And you're not going to want to get to the point where you're dependent on a stroller or like using a wheelchair. So at some point you are going to get this. And so there's the breaking point will happen when they give up too much of the things that they like to do, or that they're just having pain on a drastic measure where that it's starting to interfere with the activities of daily living. So I always tell people, like, in that situation, you don't necessarily want to wait too long, because when they wait too long, they get stiffness, which is harder to come back on the back end of the joint replacement, and they get weakness because they've literally confined themselves to doing nothing, other because everything causes pain. Well, like, especially if you're 60 and you're like, I'm going to get a joint replacement. You don't want to get to that point, because then now you just compromise your outcome on the back end. So there is a fine line of between waiting too long. Now, the exact opposite would be the scenario where I'm not saying all 90-year-olds are built alike, but and I'm probably stereotyping when I say that, but suppose you're 90 and you're very unhealthy and you got a lot of medical problems. When that situation, it's a bigger undertaking, that there's surgical risks there. And so there's a possibility where you may not have to get a knee replacement in your future. But for the vast majority of people, they try to push it off as long as they can. And it's one of those things where, like, every day they're in misery. I started saying, well, like, unless you're planning, like, if you're healthy and you're active and you've given up so much, you're only 65. Like, what's your grand plan? Like, try to get to 68. Like, your next 3 years are going to be miserable. Like, it may be time to make that jump.
Yeah, that makes sense. Okay, so I know you guys over at OAA do a lot of PRP, regenerative medicine type stuff. So tell us kind of, and our patients are starting to come to us and say, hey, I've heard, I've read some research, or, well, maybe they've just read kind of a blog post that someone wrote, but I'm more interested in the actual research and kind of the success too, because that's what patients come to us and say, well, does that stuff work? So if a patient, what patients come to you that are in the population that would do well with some kind of injection like this, and why would you choose this modality over other modalities that you might have available?
Well, PRP is coming to the forefront, especially it got a lot of press with professional athletes. Personally, I like to think that platelet-rich plasma, now, what is platelet-rich plasma? Platelet-rich plasma is getting your blood, spinning it down, and taking the growth factors from it and concentrating it up. And so platelet-rich plasma is actually found to have a lot of benefit in tissues that actually have some healing potential, but it's very, very slow. For example, like tennis elbow, where in tennis elbow, the tendon has healing potential as a blood supply, but the healing is so slow that the body kind of needs a jump start. And so that's where platelet-rich plasma has really been shown to help biceps tendonitis, your tendinitises. Now, they started using it for osteoarthritis, which is the lack of cartilage cells, which is a sort of a different phenomenon, because as opposed to tendons and muscles and ligaments, which all can heal to a certain degree, cartilage cells don't really have a high healing potential. And so what they found in platelet-rich plasma for cartilage issues is that if you have mild to moderate osteoarthritis, it can give some benefit. Now, the reason is that compared to the other injections that we give, especially steroids, platelet-rich plasma is your own stuff. It's your own cells. It does not really have a downside to it. Steroids decrease inflammation, but they also have a downside where they soften the cartilage, and they do kill a certain amount of cartilage cells. Now, not a high percentage of it, but there is some, like, chondrocyte or cartilage cell death that occurs from it. When people ask us, well, why are you giving cartilage cells? Oftentimes they say, well, in arthritis, we're treating the lack of cartilage. And if you give a lot of cortisone or steroids, you cause the lack of cartilage. So what we are actually treating is essentially what already exists. Now, in milder cases of arthritis, like exactly that 30 to 60-year-old age range, if we know that their cartilage is still overall well preserved, we start thinking platelet-rich plasma as a more holistic or natural way to decrease inflammation in the knee. Now, is it going to cure them from a knee replacement? Absolutely not. No study has ever been shown that. Can it decrease a person's symptoms so they're able to tolerate their symptoms better and push off a joint replacement? Yes, and that's where we think it has some utility.
Great. Okay. So another thing that we get asked a lot is, how much does diet and supplements, how much can they help me out with my knee pain? And, I heard this somewhere and I can't remember, so I'm just taking credit for it. But the quality of your tissue is directly related to the quality of the stuff you put in your mouth. And we see that in our end. I mean, we're more on the conservative end of care. So we're trying to kind of play the long game of, well, if you, cleaned up your diet a little bit and, you hydrated properly, and yeah, there's some supplements that have been shown to work. You could find research that proves it one way or the other. I know just from personal experience, like when I started getting a little bit older and finding that I needed a little bit of help in terms of supplements, it really did help me a lot. And there's some things that I'm taking that have helped with some joint aches and pains as my cartilage gets worn down a little bit. My socks and my boots. What a great analogy, right, Emily? I'm going to start using that from now on. I know. What when patients ask you this, hey, is there any supplements I can take or a diet I can take to help fix this problem? What is your typical response to that?
I should tell them try it. There's no harm in trying it. Different things work for different people. And the only major downside it's going to have is financial. The reason there's no real data on supplements is because the sad reality of it is that studies are very expensive, and supplements, there's very little money to be made by marketing turmeric, which is a spice, for example. And so when they've looked at it, a lot of supplements, when they look at it, when these manufacturing and pharmaceutical companies look at it, there's some data to support supplements like turmeric, fish oil, have high benefit. Glucosamine chondroitin you'll find that in your grocery stores and Costco and things like that. While the long-term data on it does not support its use, I always tell patients, listen, try it. If it works for you, just because it has some anti-inflammatory property, run with it. I mean, it's natural, it's holistic. If it doesn't work, don't spend your money on it thinking it's going to avoid a joint replacement or anything like that. But there's no harm to trying. We don't understand enough of these in terms of supplements. We don't understand enough of it to convincingly say it has a benefit or it doesn't. But that's usually my take on it. Now, in terms of diet, I tell people it definitely affects diet is directly related to the quality of your tissues. Like it definitely has a direct influence on your well-being. And the number one thing with diet is maintaining a healthy diet and not only remaining active, but weight. As we all get older, it's just much more easier to put on weight. And one of the things that we know with arthritis, even more than the activities that you do and the sports that you do, the number one contribution to osteoarthritis in the knee is weight. I see a ton of high mileage athletes, runners, active people who are very, very lean. And despite all the miles they put on their knees, you see them in their 60s, 70s, 80s, and they got great knees. Like they have done very little damage. And conversely, we see a lot of patients who are overweight. And even in their 30s or early 40s, you start seeing a lot of cartilage damage. And so one of the things I tell people is that you got to remain physically fit and just keep the weight down. Now, if you do have a higher weight, your strength needs to be proportionally increased as well. There's just some people out there who are just big people, but your knee sees a certain amount of force when you take every step, and that force is divided between the bone and the joints and the muscles. And so if your strength is tip top, well, the force may be a constant, but your muscles are offloading the joint. And so I see people who are like bone on bone arthritis and they're in great physical shape. And they'll say like, doc, my pain's like a 3 out of 10, 2 out of 10 if I aggravate it. And that's just because they're so conditioned. And even though that the joint has completely been worn out, they don't really feel it because their muscles are offloading it. It's the same concept for your back pain. Like you can have multiple bulging discs, but if your back and core is very toned, people don't feel a lot of that. And so the knee is no different.
Sounds good. Okay. So this might be one of the harder questions, but let's say someone is out there, they're younger, let's say in the younger age, somewhere between 40, 50, 60. They don't have any knee pain now, but they have friends and family members that have needed knee replacements. And maybe, I mean, if you hang around us, if you hang around a PT clinic, you're not going to want a knee replacement. It's not the funnest thing to do physical therapy for. So they want to avoid that. What advice, if someone comes to you and says, hey, I just want to try to, if I can not have knee replacements, I would love to do that. What is the best advice that you would give them?
Stay active, keep the weight down, and stay strong, especially quadriceps. Quadriceps are strength, how core strength is so crucial to it. And of course, maintain proper nutrition, and that goes into weight management. I cannot emphasize the weight management enough, and the strength. And so when people tend to be bigger people, especially the guys who used to play football in their past or wrestle, they do fine as long as they keep their strength up. We all have a tendency as we transition from those years in our life to more of a I got to go to work kind of life. It's easy to cut corners and give up some of that physical activity, but I would say make it a part of it, because once a knee pain hits, it's so much harder to get into shape at that point in time. And so you're kind of at the point of no return. And so oftentimes people say, well, doc, how am I supposed to exercise now and get my quads stronger and drop the weight now that the knee pain has started? Well, I agree with them. It's very difficult to do at that stage. So the goal is that for that person who doesn't really have knee pain yet, don't get yourself in that predicament.
Yeah, that makes sense. So a lot of the bullets here kind of echo that point. So yeah, strength fixes a lot of problems. So so now what? For everybody that has listened, we've given a lot of great information. But if you're out there and you're having some knee pain, then from our perspective, what we offer is just kind of a focus on longevity. So we have lots of different tools, everything from our ultimate guide. So we have these guides at our offices. If you want one of these, all you gotta do is call the office and we'll send you one. You just got to give us your name and your address, and we'll send one on to you. It's a 50-page guide with some information, some stuff that we talked about tonight, some other stuff that we didn't. There's actually a 90-day program for strength and mobility in that you can use. So if you're someone that has knee pain, that can help you out with that. I mean, if you're having more consistent knee pain and it's becoming a big issue, then it becomes, okay, this needs to be some kind of medical intervention. Then we offer free screens at our office. So all you gotta do is call 610-841-3555, ask for a free screen, and you can come in and get a 30-minute appointment with one of our PTs. It's really to help you make a decision. So we kind of look over what's going on and help educate you on what's happening. And sometimes we say, yep, conservative care should take care of this. Maybe getting some physical therapy is all you need. And then sometimes people can come in and say, you know what, I need to have Dr. Kalawadia take a look at this. I think there's something else going on here that might be kind of, we always say above our pay grade. There's a lot of things that are above our pay grade, right, Emily? So we tend to say that a lot. But yeah, if we need other help, then that's typically where they go. In terms of trying to make a decision about when should I go see my physical therapist, or when should I go see my orthopedist, or when should I go see my general practitioner for this kind of stuff. I think that's where people kind of struggle with that. I mean, typically, especially the population that we see, the first move is usually go to their primary care physician, but that is kind of changing, especially with the younger population. So when does someone come to see you, Dr. Kalawadia?
It's kind of all over the map. Sometimes we have patients who come in where symptoms are mild. Most times when they're seeing me, they have a sudden rise in their pain. But from kind of how you described it, it really doesn't change anything. Like a lot of times people come to me and they'll say, like, I know you're a surgeon, but I don't want surgery. So and oftentimes we have non-operative sports med people. And so patients are sometimes like, I don't want to see the surgeon, because they think when you see a surgeon, you're going to get surgery. Now, I personally am very conservative with that. And so it doesn't really matter if they start with the primary care doc, or if they don't know which direction to go, the primary care doc, orthopedic surgeon, non-operative sports med, or physical therapist. As a collective group, we're going to kind of stream them into conservative care. And I always tell patients, don't be so confident into thinking like, I'm going to get x-rays, I need an MRI, and only after I know what it is, then like if I have a tear, I need surgery. It's really not. It should almost be like, try the simple stuff, strengthen the knee. If you have pain, then get the MRI, because the MRI is only good for one thing, surgical planning. So if we're not going to start with surgery, then we don't necessarily need to start at that. And so I think patients oftentimes get very honed in on, I got a tear, how's it going to go away? And they think of it structurally, and it's not like that. It's not like the brakes on your cars, where if you ignore this issue, you're going to have a disaster waiting for you. And so, yeah, I mean, in that situation, if someone has a mild ache or pain, I think it's completely reasonable to start with you guys. Come in for a screening, start with strengthening the knee. Oftentimes, those patients do great. I never even hear about them. And so, but even if they come with us, come to me, for example, I'm probably going to direct them your way anyway. So.
Sounds good. All right. If you guys are watching this now, I didn't see any questions in the chat or in Facebook Live. If you have questions later, as this runs in our Facebook feed, you can just ask them below, or give our office a call. We can answer any questions that you have. So, Dr. Kalawadia, thanks for giving us a little bit of your time tonight. Really appreciate that and all the information. And hope everybody has a good night.
Have a good night, all.
Bye.